Why don't we transition a little bit to some of the other data sets that were presented at ESMO. Matt, I'm going to start with you for the next, which is the CheckMate 901 trial. Of course, looking at the backbone of GemCis, and could we improve upon that by comparing against GemCis plus Nivo? Your impressions of that data set?
So the first of 3 studies that combined immune checkpoint blockade with platinum-based chemotherapy to meet the primary endpoints, the co-primary endpoints of PFS and OS. The main difference in this data set is that it enrolled only patients who were cisplatin eligible, so GemCis, Nivo versus GemCis. When you look at the shapes of the curves, a lot of the action is happening in later portions of the curve. So I think this is a regimen where you get some initial stability with chemotherapy, and then you see that benefit of the subset of patients who are benefiting from immune checkpoint blockade. And this is way simplistic and a bunch of speculation, but I think some of the data is pointing toward patients who benefit from GemCis and who benefit from immune checkpoint blockade are likely some of the same patients. And I think when you give GemCis and Nivo, you're making good responses in those patients into great responses. I think, from an intratumoral heterogeneity standpoint, I think EV and immune checkpoint blockade might actually be working on different clusters of different components of the tumor. And maybe that's why you're getting this major boost rather than this minor boost.
So maybe I'll ask you a follow-up, because we had seen a sort of a hint of this from some of the other triplet trials that had gone on, that maybe the cisplatin group would do better, and now we actually saw that in a trial that looked at just that group. So is there something different about cisplatin? Is it the patients that were enrolled?
I think there is something different about it, and I don't think it's purely based on the patients who were enrolled. When you look at the IMvigor 130 data, there is, even in the patients who got cis versus carbo, taking the immune checkpoint blockade piece out of it, there is a difference in the pretreatment tumor microenvironment, the benefit that's achieved with cis versus carbo, suggesting that cis is doing something immunomodulatory in those settings. Then when you add immune checkpoint blockade to that, you get this extra benefit. So I think there's a difference.
And Terry, maybe I'll go to you, because you brought up earlier that this idea of getting immunotherapy earlier seems critical for you. This data set might speak to that as well, because a lot of people pointed out that the curves seem to start to diverge at that point, right?
Yeah, I mean, I think going back to this question of cis-carbo, if you just believe that giving immune therapy earlier was beneficial, then we would have seen benefit in the Keynote 361 study, and we would have seen benefit in IMvigor 130, which had all comers, cis and carbo. So I think there is something to be said for the partner really matters. What still puzzles me a bit is that if you look in other tumor types, carboplatin-based chemotherapy, when you add a checkpoint inhibitor to that, actually does have a benefit. Like in lung cancer, that's a pretty standard thing to give carboplatin with a checkpoint inhibitor, where you see benefit. And we don't see that in urothelial cancer. Lung cancer, urothelial cancer, very different cancer types, different microenvironment, different mutational profiles. But it is sort of intriguing to try and pin everything on just one drug and say, oh, this is just a bad drug with immunotherapy. That doesn't really play out across different tumor types.
And I think some of that complexity is that it's not just the drug, it's the drug interacting with the pretreatment tumor microenvironment. And that's why this has been such a mess, because those two pieces are hard to sort of.
Right, and I think in urothelial cancer, we've been we've constrained ourselves by putting patients with sort of different prognoses, different baseline, risk factors for doing better or worse into the same trial, and then allowing them to get different treatments in the control arms, and then trying to make sense of the results. And so that's why I think CheckMate 901 was quite a smart study, because it really tried to limit the patient population, to really sort of have that nailed down such that then you could interpret the results. And clearly the results are positive, which is great to see.
So Jonathan, I mean, it was great to see a positive trial, CheckMate 901, but is there still place for GemCis then?
I think the only place is going to be if we can figure out who those durable CRs are in advance in a highly robust fashion, because there is, there is an attraction to giving just 4 or 5 months of chemotherapy and then stopping and continuing a maintenance checkpoint. But if we can't pick those people out of the crowd with any high degree of efficiency, I don't see a real role in broad populations. There may be selected weird scenarios where you might not want to give EV Pembro, But I think there's some tantalizing hints around DNA damage repair mutations. It's not clear that they play a huge role in the metastatic setting compared perhaps to perioperative therapy. There may be other biomarkers that we haven't really interrogated, but they're going to have to be very robust if we are going to identify that subset of patients. And I don't know that we're going to necessarily get there.
I will just add that it's not only the chemotherapy part in 901 that's a fixed duration, but actually the immune checkpoint blockade's fixed to 2 years. And so in the 20% of patients who had a CR, the median duration of response was 36 months. So there's a median of a year of a treatment-free interval in those patients. And I mean, if that's something that's important, that's I think a key piece of the 901 data.
I might just add that it's hard to figure out, just to go back to Jonathan's original point, who's someone who would be eligible for cisplatin chemotherapy who's ineligible for EV Pembro. And you cited earlier neuropathy as well as sort of hyperglycemia.
I didn't say they were good for GemCis.
Right, which are unfortunately both a problem because of the steroids needed for cisplatin use and the neuropathy that cisplatin causes.
Right.
So I've been wrestling in my own head with who is going to get this regimen. I think from a financial perspective, cisgem and nivo is going to be much easier to the health system. At least here in the US, I don't think that is necessarily as an important a factor as it might be in other countries. So it'll be interesting to see how these approvals play out across the world. In terms of EV Pembro versus a cisgem nivo regimen. But if I have both options in front of me, it's very hard to know who would be eligible for one but ineligible for the other.
I'm going to go back to something Matt just brought up about this duration of the immunotherapy in the 901. Also in the EV Pembro trial, the Pembro was stopped after 2 years by protocol. And now we've got bladder cancer patients that are living 3 years or more. So is that what we're doing in practice? Maybe I'll start with you, Jonathan. Do we stop our immunotherapy at 2 years just because the trials did that?
I've generally been doing that. I've had a few patients flatly refuse to stop, and I haven't fought them that hard on it. But I've been trying to, in really good responders, it's not clear that it really matters to continue beyond, and there's good data to say that many of those responses are durable. And my own gestalt is that if they progress, they probably were going to progress anyway because they often don't respond to reinduction with immune checkpoint blockade.
Can I quick hits from me?
I have the same experience. I find that it's usually me trying to convince someone to stop, and it's hard for me to feel comfortable with that discussion because then if something happens off treatment, of course you feel terrible. So it's a hard discussion to have.
Yeah, I mean, I think this is a strong call for biomarkers, right? Cell-free DNA has been used as a sort of prognostic marker for recurrence after cystectomy, and perhaps there's a role for this in the metastatic setting, such that if patients' cell-free DNA goes down to 0 or undetectable at some point, perhaps stopping therapy would be okay. It's not proven. We don't have any long-term prospective data to validate that, but at least it's sort of an intriguing question. And so I've had patients who are past 2 years with checkpoint inhibitor who are very reluctant to stop because this is the one drug that's keeping them alive. They thought they were going to die within 9 months or 14 months of diagnosis, and here we are at 2 years or sometimes 3 years, and they really don't want to stop. And so we've talked about cell-free DNA, and we said, look, maybe if the cell-free DNA is negative multiple times in a row, maybe it's time to stop, and the scans look good. And I've actually successfully stopped people who are now at least out a year from that without relapse. That's anecdotal, so I don't want to dive too deep into that, but I think it's a pretty intriguing biomarker.
I think we all have those anecdotes.
Yeah.
I also have the anecdotes on the flip
In the
side,
reverse.
whereas I have a number of patients who were off treatment for other reasons, and it was before ctDNA MRD testing became commercially available, and now testing it, you can find minimal detectable ctDNA. Patients who have been off treatment for a year with no evidence of disease on scan. And so I completely agree with you. That's a study that needs to be done. It's a very straightforward question.
Yeah, sort of like a PSA from the prostate cancer world for bladder cancer.
At the same time, we don't know that those patients don't have disease controlled by their immune system and that there's a bit of tumor that's still living in them. And and we don't know what's going to happen.
Right.
I also have at least one person like that, and they've been off treatment for a year and a half, and nothing has happened with a stable, very low level of ctDNA.
Interesting.
I also, we haven't lifted the hood on those assays well enough, I think, in the companies that are doing them. haven't shown us what they're actually doing.
Right.
And so I don't know if they're looking at clonal hematopoiesis. That might have been in some of the cells in the original tumor.
Yeah.
Like we just are not, so I have a little bit of skepticism of some of those tests still. And so to be determined as time goes on.